all these approaches depending upon the indication what we're dealing with, that is the cancer type, and we try to use it for all the patients with the same indication, a similar type of therapy, what we used to call as blanket therapy, or the approaches used to be called as one-size-fits-all approach. But the precision oncology approach, which is a very unique approach, the contemporary approach, we will try to find out what is best for the patient.
For many years, customized therapy has been a priority for healthcare professionals. The idea is to maximize the benefits and limit the damages. Each patient should get medication only as according to their clinical needs. This concept is being used from 1960s and 1970s, leading to the phrases like the right drug for the right patient, in the right amount, at the right time. With our understanding with precision medicine, we still use these terminologies. However, what has changed from now to then is our increased understanding of molecular medicine. In today's GénieCast session, we'll learn more about personalized cancer medicine from Dr. Amit Verma. Dr. Amit Verma is the founder and director of Dr. A.V. Institute for Personalized Cancer Therapy and Research. He is a well-known molecular oncologist and a cancer geneticist with about 15 years of experience. He believes in contemporary approach towards cancer treatment, popularly known as Precision Oncology. Welcome, Dr. Amit Verma.
Thank you, Payal.
So, Dr. Amit Verma, it's been 20 years since we've been hearing about personalized cancer medicine. Can you actually throw a light and help us define what is personalized medicine or personalized cancer medicine?
A very interesting question, Payal. Personalized cancer medicine, the word itself says that we are giving a personal touch to the patient treatment. And this can be given by the medical oncologist, surgical oncologist, or the radiation oncologist for that matter. But when we try to use the genomics into the decision making, we try to call this personalized cancer medicine approach as a precision oncology approach. So this is about the personalized cancer medicine and the precision oncology.
Right. So I understand the regular treatment of how cancer treatment used to be, say before 20 years, had a certain impact on the treatment. How has personalized medicine changed the impact or the newer age therapies? How is it different from the past using personalized medicine approach?
So the treatment remains with the similar modalities, the chemotherapy, the target therapy, or immunotherapy for that matter, radiation and surgery. So these are different modalities which remains the same. But how to use it, when to use it, for whom not to use it is the key thing. Earlier we used to use all these approaches depending upon the indication what we're dealing with, that is the cancer type, and we try to use it for all the patients with the same indication, a similar type of therapy, what we used to call as blanket therapy, or the approaches used to be called as one-size-fits-all approach. But the precision oncology approach, which is a very unique approach, the contemporary approach, where we try to find out what is best for the patient, where we can have the less side effect, where we can get the best responses to the treatment, and mainly and primarily it is based on the patient tumor genomics and the patient constitutional genomics. And this is what we call as precision oncology. What we have learned over the years that this approach seems to be better in terms of giving better response rates, in terms of giving better progression-free survival, as well as the overall survival. It has been proven at multiple levels that this genomic-based approach or biomarker-based approach is far better than the conventional blanket approach.
Right. So I think still there are these two terms that I just heard, personalized cancer medicine and precision oncology. And I feel even in this, we feel a lot of patients or doctors interchange it or use it. So are there similar terms with two names, or they mean different things?
Okay, so personalized cancer medicine approach, as I just mentioned, is a personal approach to the treatment actually. And precision oncology approach is the personal treatment based on genomics. A personal approach can be tailor-made on the patient performance status, the social status, the paying capacity, and then the other comorbidities the patient has. So this is can be a tailor-made treatment for the patient and can be considered as personalized cancer medicine.
Okay.
But when I use genomics, what tumor DNA says, what type of mutation the patient harbors, what target therapy can work for the patient, and then apply that information into the treatment paradigm, that makes the thing called precision oncology. So you can say personalized cancer medicine is an umbrella and precision oncology is a part of it.
So, how is precision oncology being used for patient therapy currently?
So as of now, precision oncology is used in scenarios where the conventional treatment fails. Normally at the later stage of cancer, when they try to, when they progresses or when they relapse or at time of recurrence. This is the current norm. And normally, what we do is that we take the patient tumor sample and also sometimes blood and try to understand the DNA as well as RNA on the tumor, what we call as somatic analysis. And on the blood, we try to understand at the DNA level what we call as the germline or constitutional genomic makeup. And then we try to see what is the or what are the alterations, what type of target therapies we have. Does the biomarker suggest any prediction to response to immunotherapies? Does it predict the responses or resistance to certain type of target therapies? So those information are taken into account and then it is applied to the patient in the later stages of the treatment. Earlier, the early lines of treatment are standard treatments which are based on the guidelines. We tend to follow all the guidelines. But when these guidelines are not able to give better outcomes, we tend to go with this approach of precision oncology.
Okay. So I understand in precision oncology you said there's somatic analysis and germline analysis. How are these analysis essentially done? Is it some complex tests?
So these are quite complex tests. The somatic analysis is normally done on the tumor biopsy block, whether it can be a biopsy block or it can be a surgical specimen, which is kept in a paraffin embedded block. And this is used for the somatic analysis where the DNA is extracted and then variety of tests are carried out, which includes variety of tests which can give us answer in terms of the expression at the protein level, expression at the RNA level, and also alterations at the DNA level. So these are the major headers of the somatic analysis. Somatic analysis also can be carried out on the blood, what we call these days as liquid biopsy. As we know that most of the DNA, when the tumor cell die, is leaked into the circulation.
Right.
And that circulating tumor DNA can be picked up by the latest technologies and can give us some clues what is happening in the primary site of the tumor. And that information is considered to be a somatic information that is specific to the tumor type.
Okay.
Or the tumor per se.
And specific to that patient.
And then on the other hand, the germline, what you just mentioned, is the constitutional makeup, how we are made up, what is our genetic makeup. All these cells will harbor the same genetic alterations, and this is normally done either on the blood, where we take the white blood cells and understand the constitutional genetic makeup, or we take the saliva, where we have access to the cheek cells, where we can extract the genomic DNA. So they are the two important sources for the germline testing.
Yeah. So I heard some, battery of tests, and are they all available in India? What are the modalities they are tested on, or the instruments, platforms? I mean.
Yeah, so very, very important question what you have asked. So it's a variety of tests. The importantly used in the precision oncology is the immunohistochemistry, cytogenetics, FISH technologies, microarray, and also the next generation sequencing. All these technologies as of now are available in India at a far cheaper and affordable price as compared to the Western world or the European countries. So India is far ahead in delivering all these types of tests, which are practically affordable for the Indian patients.
Yeah. So you mentioned a battery of tests. So it's either one or combination of those that are required. for the patient?
So, depending upon the type of cancer we are dealing with, there are some common alterations, and all the tests are not perfect tests. So, we have to combine a couple of tests to get some answers. So, as we are not looking for single answers, we are trying to explore the various possibilities the tumor may have. So, we tend to go for multiple combination of these battery of tests and see what comes for the patient. Sometimes we don't normally recommend a test what we call as comprehensive genomic profiling, which includes the which have a pickup rate of picking up different types of alterations at the DNA level, but but they also lack in terms of expression at the protein level. So practically speaking, we have to use battery of tests to reach to the conclusion what exactly the patient is having.
Okay, so again, I understand the kind of tests that you're saying are complex tests. So, when should a patient do it in the life cycle? At diagnosis, or only when the routine therapy is not going right?
So, what you have asked is a very practical question. In our clinical practice, we see that most of the patients refer to all these kind of tests at the later stages. Few of the standard tests are part of the guidelines which are used early on, but the few of the complex tests are reserved for the later lines.
Okay.
But I personally recommend to use all these modalities upfront. More the information you have, the better you can plan the treatment for the patient.
But if these tests are done upfront and then the patient takes therapy, doesn't the outcome change if depending on the timing when it was done?
Uh, so what I understand that if the test is done upfront, the treatment based on these tests is definitely going to change the outcome
Okay, because you'll modify the treatment from beginning.
from the beginning. So the outcome will be better, as I have already mentioned that the overall survival is impacted if you use these biomarker-based approaches.
All right. These tests seem pretty. I mean, they look complex, but is the outcome a straight yes or no? Like yes, these drugs, no, not these drugs. How do the outcomes look like?
A very interesting question, and it is not very simple science. It is a very complex science in itself. As I have just, I wanted to apprise you of the fact that the tumor DNA or the human DNA consists of so many genes, approximately 40,000 genes, out of which approximately 500 genes are relevant for the tumor to grow fast or to predict that these drugs will work and or these drugs won't work. These are the complexities, and these approximately 500 genes have various alterations, and the combination of these alterations and the combination of the different expression of these altered genes is going to affect the patient tumorigenesis, the outcome finally. So these reports are not easy to interpret. It has to be taken in conjunction with so many parameters, along with the clinical status, and it has to be taken in conjunction with various experts, along with the medical, surgical, radiation, molecular oncologist, as well as the geneticists like you, and and also pathologists who will help us to find the best treatment option for the patient based on these complex reports. So it is not straightforward. So this is a very complex reporting and needs a lot of due diligence, lot of homework before we can really pin down that this is the best option for the patient.
So, Dr. Verma, you mentioned about a lot of stakeholders that need to be involved in taking a patient decision. So, how is it arranged? Like, how do all of them give their inputs on one patient?
A very interesting question. So we have a concept of molecular tumor board where all the people sit together in a room to discuss a case, or if it is not feasible, we try to sit virtually. So we normally offer these cases to the individual specialist, and the individual specialists give their comments, and these are collated to form a consensus actually. So these kind of services are currently offered by Dr. AV Institute for the patient, where we do a lot of second opinions as well as the molecular tumor board services for the national patient as well as international patient. The patient do have access to the key experts of the tumor board if they have further queries to resolve it. But yes, it is possible these days with the advent of so many technologies where you can meet virtually, record all these things virtually, and then give a document about it.
So is patient party to this conversation, like you said, molecular tumor
So
board?
most of the time, no. But if the patient wishes to be a part of the discussion, we never say no to the patient wishes actually. But we try to make the patient as a silent listener because there's all lot of medical jargons which are being discussed across the table. But yes, the patient has the full right to have access to all these information and discussions and participate as and when required. And definitely, the patient can ask questions to the specialist directly or can be prepared prior to the meeting actually.
Right. I've of course working in this field. I've heard about tumor boards, which were very hospital specific or unit specific. But it is interesting to know how it has crossed the boundaries and walls of hospitals, and now molecular tumor boards is actually accumulation of a lot of doctors practicing across areas, across across experiences. And it's very interesting that Dr. AV Institute has a virtual molecular tumor board that also gets patient an opportunity to get an international doctor's input. For you as a molecular oncologist, if a patient would like to come to you, when and why and what kind of patients should be referred to a specialist like yourself?
So, as I just mentioned, that I normally recommend all these high-end investigations or understanding of the tumor genomics upfront. We recommend that the patient who want to choose the contemporary precision-based oncology approach, they should come as early as possible, even at the time of diagnosis. We are sometimes able to help the patient to find what are the best ways to stage the patient, what are the best ways to treat the patient. So these things are very, very helpful in certain points. So definitely we would love to see the patients early on so that we can advise them better. But nevertheless, if the patient have been undergoing any sort of treatment, um, they can come during the treatment as well. And certainly they are strongly recommended to approach us when the treatment starts failing. So where we can offer them some
Of
more
course.
options.
I just like to reiterate, I understand when a diagnosis is happening, there's a lot happening in the family, there's a lot of chaos, and everybody just wants to urgently start the treatment. But it is important to take a deep breath, take a couple of steps behind, and see a molecular oncologist or a person who practices precision oncology to make sure that the entire spectrum of things is considered before they either go for a one modality of treatment right away. So I just wanted to reiterate this point for our listeners. It'll be interesting to know one of your patient journey. Can you walk us through it?
So this science is evolving science, and the way we used to practice is that whenever we do some genomic test, we find some answers we try to offer to the patients. But as evolving science, the guidelines are also evolving. What was not the treatment earlier is now a treatment in the guideline. So we have to be very, very watchful of the new developments happening around. Most of the time, the genomic information what we get is a robust information which is quite good for some time during the course of the treatment. You may not have treatment options now, but maybe in the later time when the new drugs are available easily. So, having said that, I would like to share one of my journeys a couple of years back when we had a case of ovarian carcinoma which was metastatic, and she had the standard line of treatment, which was the chemotherapy and surgery, and then she had a quick relapse, and unfortunately, her relapse happened within a year's time, and then she was offered the second line of chemotherapy, again, which did not do well for her, but she progressed on the second line of chemotherapy. She happens to approach us, and we investigated the tumor and the somatic analysis was carried out using the comprehensive genomic profiling. And what we encountered was a mutation in a very important gene that is called BRCA gene.
Okay.
And we did some germline testing to understand whether this germline test also pick up the BRCA mutation, but this was not there. So we labeled it as a somatic mutation only. So at those times, we did not have a strong guidelines or guidance to how to use that somatic information. But we did go ahead and start the patient with PARP inhibitor, and the patient did well, had a disease-free interval of more than 2.5 to 3 years, and then she progressed later on. So by the time when the patient progressed, now the guidelines have started to recommend to use PARP inhibitor for somatic mutations. So this is a dynamic situation as well, and this was a very learning curve for most of us. But we were lucky that the patient was very much compliant to our suggestion, and it really helped the patient when the treatment options were not working for her. So it is one of the success case stories which I want to share, but we have plenty of such case stories for all the cancer types, not only ovarian cancer for that matter, for lung cancer, for gallbladder cancer, for brain tumors, for colon cancer, for prostate cancer. So it can be applied to all sorts of cancer. It is just a sheer chance that what you hit, if you are lucky, that your tumor suggests some treatment options, and if it is applied early on, you may get the benefit. So this is one of the case studies which I want to share with you.
Great. So if I just summarize what I've understood is if a patient is diagnosed with any type of solid tumor cancer, they first ideally come to you at diagnosis, and depending on the type of tumor type, you would advise a battery of genomic tests that would tell what next. Or they can come when during the treatment, if they would like to take the precision oncology approach, or they could also consult you or someone specific doing precision oncology when a certain lines of chemotherapy fails, and then they will see if they need targeted therapy based on the test outcomes, or immunotherapy, or some other modality that needs to be prioritized, right? Is my understanding correct?
Yes, certainly yes. So the recent data suggests that certain approaches, like immunotherapy approaches, when we use early on, have an impact on the overall survival. So those approaches are not standard treatment guidelines. We have chemotherapy as a standard of treatment or target therapy for that matter. But as the science is evolving, we are seeing a big change in that trend. Early usage of immunotherapy is coming up.
Okay.
Early usage of target therapy is coming up. And chemotherapy is kept for the later lines of the treatment. It is, we are not saying or suggesting that the chemotherapies are obsolete, but we want to avoid them as much as we can, as we know that chemotherapy have a toll on the body as compared to target therapy, which certainly will have the side effects, but as compared to the chemotherapy, they will be relatively less and relatively less severe.
So, since we practice evidence-based management for oncology in India, is my understanding correct, right?
Correct.
So, you cannot start a patient on any therapy without having a report or a diagnostic report that suggests so, right? A gut feeling or a best approach or a best way or best right foot forward is not precisive, I guess. Right?
Yeah. So experience versus evidence is what we are talking about, and I think evidence supersedes the experience in this particular scenario.
In precision
In
oncology.
precision oncology, so if you have the data pointing out or evidence suggesting that this drug works for this mutation, certainly we are confident it will do work. So this is very simple and straightforward.
Alright. So, we understand that one size fit all had a certain impact on the therapy, and with precision oncology, we just understood through the session of how the therapy options are becoming more focused, and the overall benefit to the patient is much higher. What does future look like in personalized cancer medicine overall?
So I see a future where our patient is going to walk into the doctor's clinic, While they're talking about their signs and symptoms, they will also give their samples for the analysis. By the end of a day or by the end of a week, you will have a comprehensive report which will not talk about the clinical status of the patient but also the genomic status. And combination of this clinical and the genomic information, a best treatment approach will be offered to the patient, and all of those treatment options will be artificial intelligence based. So this is what I envision for the precision oncology in the near future, and I think this is not far away. I am expecting that thing to happen in less than a decade's time.
So अच्छे दिन आ रहे हैं.
Actually, अच्छे दिन चल रहे हैं.
Absolutely. Thank you, Dr. Amit Verma. This has been a very clear understanding of how personalized cancer medicine is being approached and why precision oncology and what are its benefits. We really thank you for your time today.
Thank you, Payal, for lovely discussion we had today, and I think it would be informative for most of the listeners in the audience. And if you have any concerns or queries, we are more than happy to help you out.
Yes. Thank you.
Thank you very much.